Good morning, everyone. Is everyone able to hear my voice? Okay. Welcome to the Informs 2022 at Indianapolis. So today is the first tutorial session. So the speaker of the session would be Ujjwal K. Mukherjee. Ujjwal K. Mukherjee is an associate professor at the business administration at the University of Illinois at Urbana-Champaign at the Guy School of Business. He has accomplished a major academic accomplishment. He received his master's in statistics and PhD at the University of Minnesota in business administration. And also he has an MBA from Xavier Institute and bachelor's and master's from Jadavpur University. He has done amazingly in research. So his research has published in wide range of journals from Scientific Reports, Journal of Clinical Oncology, MSOM, Journal of Management, POMS, and so many other journals. So this tutorial he's going to talk about epidemic modeling, prediction, and control. The topic is basically about, as we know that COVID-19 has disrupted everyone, in every facet of life. So Ujjwal is going to talk about some preliminary models of, or existing models of in epidemiology and the strength and weakness of it, and how to include some individual traits into this behavioral models, and he's going to conclude with the lessons learned from the existing COVID-19 and some ideas about how to manage future pandemics. I would like to welcome Ujjwal K. Mukherjee, and the board is for you.
Thank you, Pradeep. Thank you, Pradeep. I just want to make sure I am audible, right, at the end? Okay. So my name, as Pradeep introduced me, he introduced me better than I can do. So my name is Ujjwal Mukherjee. I am an associate professor at the Gies College of Business at University of Illinois Urbana-Champaign. My research primarily focuses on healthcare. I do a lot of work in healthcare. I have a 33% appointment with the medical school at the university and 67% with the business school. So I do a lot of clinical kind of healthcare work along with my management research, which is also primarily focused on healthcare. But for the last few years, I had been working with FDA on a sponsored project, and therefore I also work in medical devices and pharmaceutical industry a bit. So and that's about me. So this tutorial is on epidemic modeling, prediction, and control. First of all, I would like to thank all of you and invite all of you to the very first session of Informs 2022. It's the full in-person Informs after a few years. So this is exciting to be here and to be able to talk to each other and to be able to interact with each other, right? So that's very exciting, and this is the very first session, 8 o'clock in the morning. I come from Champaign, not too far away distance-wise, but it's 1 hour behind. Pradeep comes from Oregon, which is 3 hours behind. So for many of us, those who come from the West Coast or maybe international locations, it's a bit of a jet lag that is there right in the morning, but that's okay. I hope to make it interesting. So this presentation was supposed to be with Sridhar Seshadri and myself. So Sridhar is my colleague, but he got stuck up for some personal reasons. He could not come, so I'll represent him, right? So the work that I will present here, or it's an overview of many works that I will present here, actually comes from working with this team, COVID team. It's called the Heart COVID-19 team. At the onset, so just to give you a background of what it is, at the onset of COVID way back in 2020, March 2020, our university formed a university level team including faculty members from engineering and biological sciences. So Dr. England is a infectious disease specialist from Carl and OSF, which is the university hospital, right? Then we have Anton Ivanov, who is an assistant professor, Eren Ahsan. He used to be with Mount Sinai earlier. He is also a biomedical engineer, right? So Ron Watkins, he is the director of Shield, Illinois, UIUC, and he is also the director of Shield, Illinois, not just UIUC. So the whole state of Illinois' K-12 testing program, right? So he has been responsible for rolling out the testing program to 1,900 K-12 schools in Illinois, and so far they have conducted more than 5 million tests all across Illinois. So this is a test that the university developed, the team developed, not this team, but another team developed, right? So then we have Sebastian, who used to be with us. He is with Rensselaer Polytechnic now. So Shuai Hao, he is a PhD student. He did a lot of the work that we are going to present, Sridhar. Subhamesh Bose, who is in the electrical and computer science engineering in EYUC, and he has been responsible for also much of the theoretical work that we did with this team. Myself and Yu Qian, who is currently at the University of Chapel Hill, right? So this is the team. So the idea of the team formulation at the beginning was to help the university to combat COVID, right? To roll out the testing program, how many people to test, where to locate the test facilities. And we did end up providing inputs to the state of Illinois, and we presented to the governor's office, to the city of Chicago's mayor, and our inputs were, at least I hope, somewhat helpful to the state of Illinois as well as to the university, right? So initially the team was kind of very practical focused, but we being academicians, we always find out research ideas and research opportunities and paper opportunities from this work, right? However, the objective of the work was purely practical, how to combat COVID, and we did actually contribute to some extent at least, right? And that's why I actually enjoyed doing this work, and with this team it was a fantastic team. We still work, but not on COVID. At this moment we are working on rural healthcare, so we have applied for a grant on providing rural healthcare kiosks to different locations and doing a field study. So that's what we have moved to. However, the work that I will present here mostly comes from our experience of working with this team. So this is the agenda. So I'll give you an overview. COVID is so close to all of our experience that almost all of us know much of the data that I will show here, right? But I'll still give you an overview. Then I'll discuss a control theoretic model on modeling control actions of COVID. So this is a specific model that we had constructed, and we had we have published this also at this moment, right? So I'll discuss that. So policies for school reopening. So this was the primary work that we had done, and we will talk about it and how it applies to small population, right? So an illustrative example of machine learning based prediction, modeling super spreader events. So these are some works that we digress to while doing these policies for school reopening, and then behavioral issues, right? So this is another work that we have done recently, and we are in the process of publishing the paper, and conclusions and lessons learned. So this is the agenda, right? Feel free to stop me and ask me questions. I have prepared for around an 1 hour's presentation and 15 minutes for question answer, but it need not be sequential, it can be concurrent. You can ask me questions as I go. Does that sound good? Okay, great. So again, just to start, let's see the COVID cases that were reported globally, and the death case, the number of deaths unfortunately were reported globally. The total numbers are quite high, but what is observable is that there is quite a bit of uncertainty in these graphs, right? It moves in waves. These waves are primarily driven by the emergence, and the sudden emergence is almost impossible to predict when it will emerge. Sudden emergence of different variants, for example, the second wave was primarily driven by the Delta variant, right? And then the third long wave was primarily driven by the Omicron variant, and it's still being driven by Omicron variant, but different subvariants of Omicron, right? And the death cases had been going this way. Obviously, the vaccination program helped quite a lot, right? So one thing that we can see from here is that, first of all, it's very unpredictable. The diffusion path of pathogen like COVID pathogen, the SARS-CoV-2 pathogen, right, or its variants, is very unpredictable, right? First of all, because of the emergence. Second, because of the complex spatio-temporal dynamics, right? So, and therefore, managing it is also kind of important, but also difficult, right? So if we look at different regions, so we see that there is some amount of conformance across different regions. Obviously, the conformance comes because of the spatial dependencies across these different regions due to mobility and transfer of people from one region to other region. However, there's also some amount of discordance, right? So some of these graphs, when it grew in one region, it did not grow. So some regions follow other regions. For example, this grew here, and then this region followed the growth, right? Okay. So this just demonstrates the spatial dependence. So now coming back to the US, these are the graphs for US. It's pretty much the same, it's nothing different. If you look at the ICU demands, again you see the hospitalization and ICU demands are significantly variant across different time points. Now this creates a problem because you need to be prepared for the surges of ICU demand, and how do you manage the surges of ICU demand is an important point, right? Again, if you look at the death rates is still very unpredictable. Okay, so to give an overview of what are the issues, so what are the issues that we faced in these last 2.5 years, right? So first issue in terms of managing COVID, that what are the primary aspects of managing and modeling COVID-19? So first is prediction. It is important to predict the diffusion of a pathogen with precision. However, there are significant challenges. So particularly for COVID, asymptomatic spread was a big challenge. The primary modality of COVID transmission or diffusion across a graph of locations is the asymptomatic people, right? The asymptomatic infections, right? And that was one of the challenges because there's not a good estimate of asymptomatic infections, right? Sparsity of signals, particularly during the initial phases of the diffusion of the pathogen. Initially, when the pathogen started growing, there was sparsity of signal. It was impossible to filter out a signal of how the diffusion path will move in the future, especially for the smaller locations, right? For big cities like Cook County and New York City, those were at least beyond the initial phase was primarily driven by population density internally. However, for the smaller locations like Champaign County or in Illinois or other smaller counties, which is driven primarily by external infection, right? But due to sparsity of signals in the initial stages, it was not so easy to predict, right? So that's another challenge, right? Complex spatial dependencies and mobility driven, right? So because of the complex spatial dependencies, is difficult to predict again given sparsity of signal. Long-term temporal dependencies. So the first variant of COVID, the alpha variant, if you remember the peak infectivity point, the virus shedding time period was from the 3rd day of infection till the 10th day of infection, right? So you can imagine that there is it's not a purely Markov process like the standard SIR models. It has long-term dependencies, right? And it indeed has long-term dependencies. So that's something which most of the current models do not account for. So that's another challenge. Latent unobserved population level factors such as sentiment and behavior. So one thing COVID has shown us is that behavior matters, right? The behavior of the individuals as well as behavior of the population matters, right? So in terms of mask wearing, in terms of social distancing, in terms of all preventative measures, there is a natural social cost of preventative measures, social and economic cost of preventative measures, right? However, there is also a health cost of not taking the preventative measures. So how individuals behaviorally evaluate the different costs is important, right? So not many of the current models account for behaviors, right? We will give you some examples of this. Role of super spreaders, right? So during the COVID, because it was a long time period, starting from, at least in US, globally starting from December of 2019, and it's still going on, we are still not over it, right? The death rates have come down, the fatality rates have come down because of vaccination and some amount of herd immunity. However, it's still going on, right? So we are still into it. And during this long period, there had been several super spreader events. So one example is the election in the United States. There were mass gatherings in different parts of the world, and those events tend to provide a shock to the diffusion path of the pathogen, right? And that can upstart the. And finally, it's interpretability, that there are different models you predict, but how do you interpret? How do you convert that into a policy decision, a mitigation decision, or an operations decision? That's important, right? So for example, when we started working, we built some models, complex statistical models with long-term dependencies and different distributions, and we accounted for a lot of the factors to make it as real as possible. Obviously, there's a lot of uncertainty in the prediction. So the prediction that you get, the first question that the university would ask, or any organization or any policymaker will ask, that how do you interpret these predictions? What do I do now? How can I reduce this, right? And that interpretability is an important challenge, and because of the complexity of the diffusion process, interpretability sometimes is a problem, right? The second is control actions. How do you decide on optimal control actions, or at least reasonable control actions? So in case of a non-stationary time series, or a very dynamic time series like epidemic diffusion, even if we cannot talk about optimality, we can talk of near optimality, or at least reasonable control actions. How do you undertake reasonable control actions? So the objective is to minimize the social cost of pandemic, total healthcare cost, mitigation, and economic cost. So the sum total of that, right? And there are trade-offs, obviously, right? So we listed down the different long-term actions. So on two axes, first of all, the demand side and the supply side of things, right? So different actions, do they act on the supply side in terms of mitigating the death rates, right? In terms of curing, and the demand side in terms of preventing, right? So it reduces the demand for healthcare, and this is the supply side of healthcare, right? So invest in ventilation, ICU capacity, nurse and doctor capacity. This was one of the initial activities that we did, and from this team also in our university, and the engineering team that was working with us, and I was a part of the team, we built a ventilator. We designed a ventilator, we built a ventilator, we outsourced it, and we built quite a few of those and distributed it across hospitals in Illinois, right? So that was one of the initial activities that we did, right? So how do you build ICU capacity? How do you build healthcare capacity in such a short time frame? That's very important, right? So, but that's a short-term measure, and it also acts on the supply side. It doesn't do anything to prevent infection, or it is not focused towards preventing infection. It might actually, but it is more from the supply side, that given infection, how do you reduce the death rates, right? Similarly, prioritize admissions and ICU resource allocation. So that's another important thing to understand, right? Similarly, if you look at the supply side long-term actions, invest in curative therapies. We still don't have a therapeutic solution for COVID, right? So there are researches going on, but that's one of the long-term actions. So policymakers, in terms of funding, in terms of providing focus, can actually help in development of curative therapies. Create healthcare capacities. How do you build long-term healthcare capacities to mitigate any future events like this? So that's another action, control action, right? Then coming to short-term demand-side control actions. Much of the initial control actions, the first reaction, and rightfully so, were focused towards the demand side. How do you reduce the number of infections? How do you prevent the infection from diffusing over different locations? If you contrast the actions, the policy actions at that time in 2020 versus now, we have entirely moved, at least in US, we have entirely moved from the demand side to the supply side. We are not controlling the demand side. We are meeting together. Obviously, the Omicron is still going on, and if you check up, the daily number of cases in US is still 30,000-40,000. The number of deaths is also 300-400. That's the 7-day average if you check up online. However, we are mostly focused towards the supply side, that how do you reduce the death rate by vaccination, by different therapeutics, by different building capacity, given that we will have certain amount of infection. It's going to be endemic in future, right? But initially, testing, symptomatic and asymptomatic testing, and identification of infected individuals, right? That was one of the initial control actions. Testing, resource allocation, contact tracing. In our university, we implemented from this team, and also there were other help, right? We implemented a contact tracing program through a mobile app, and it worked very well. It worked very well. I myself received a call one day. I was teaching at that point of time. That was like fall of 2021. I received a call that one of your students have been detected positive Why don't you go and test tomorrow? Unless you test tomorrow, you don't have access to buildings, right? So we built that kind of a contact tracing program, right? So I went and tested. Fortunately, there was nothing, right? So lockdown and isolation. Lockdown was one of the very initial actions. Many different locations locked down, many different countries locked down, big economies locked down. There was obviously a big impact, the big cost on the economy and the social side, right? Job losses, social impact, right? There were behavioral health related impact, right? However, that was because at that point of time we did not know the nature of the pathogen. We did not know how to control. We didn't have enough testing capacity. We didn't have enough ventilation capacity, right? So lockdown and isolation. But however, so this is one thing that I will demonstrate what we did, right? Mobility restrictions, that's again lockdown. Mask wearing and social distancing measures. Similarly, invest in vaccination, so demand side and long term. Vaccine prioritization, how do you prioritize vaccination, right? Asymptomatic testing, identification and isolation, right? So awareness building and behavioral changes in the long term. So if you look at some of the recent NSF call for proposals and NIH's call for proposal, there has been a few funding opportunities and funding call for proposals on understanding behavior in COVID, not just COVID, in epidemics, right? How do you build models that incorporate behavioral aspects of epidemic transmission, right? So the challenges are again prediction accuracy, inherent uncertainties, short time to act. Then behavioral issues, understand and increase prevention compliant behavior. How do you understand prevention compliant behavior? What factors are related to those behavior, and how do you improve that? How do you intervene into that, right? So the challenge is behavior is latent. It's difficult to understand behavior, right? It's difficult to estimate behavior. We have signals. From our team, we mine Twitter data, other social media data to understand behavior. It's an imperfect signal. It's a very noisy signal, right? Behavior can be persistent and difficult to change. We saw that during COVID, right? Unfortunately, it somehow got politicized, and there were like different viewpoints, opposing viewpoints, that masks work. Some said masks do not work. Some say social distances work. Some said social distancing did not work. So there were different, and those are persistent behaviors, right? Understand policy levers that account for behavior and that can change behavior, right? But at least that can account for behavior. And I will demonstrate one example here. So these are some example work that we did, and I will be going into those. Okay. So beyond mitigating, we looked at what are the consequences of COVID-19 pandemic, or at least what are the long-term consequences of COVID-19 pandemic, or long-term consequences of epidemics of this nature, right? So one is healthcare delivery, that how do you manage risk factors in the long term, right? Capacity constraints, how do you build capacity in the healthcare system to mitigate any such future occurrences. Remote healthcare delivery using technology. So we are working with OSF and CURL now, and beyond COVID actually, to understand how can we improve the adoption of telehealth, right? So OSF has a telehealth platform, and CURL also has a telehealth platform. CURL is the university hospital, that's the teaching hospital, right? They have a telehealth platform. The adoption rate is low, but more than that, the usage rate is even lower, right? So people use it for some time and then they drop out, and that has been a problem. So how do you improve that? This is important because the primary care capacity, especially with all the social healthcare initiatives, is not sufficient to address the healthcare requirement of the future. There's a huge amount of nurse shortages. Healthcare organizations are suffering from nurse shortages. I work with this hospital. I have a 33% appointment with the CURL hospital, and the big question that we discuss about is how do you address nurse shortage? How do you reorganize the work that the nurses do to actually better utilize the nurse capacity that we have, right? So those are issues that we need to deal with. On supply chain side, how do you manage supply chain disruptions? So how does electronic supply chains, electronic retailing play a role? Inventory strategies, can you create strategic buffers, especially in healthcare, right? Especially in emergency healthcare inventory, how do you create strategic buffers? Long-term supply chain resilience, there are many different ways in which you can create long-term supply chain resilience by diversification, geographic diversification, or even supply source diversification, right? And then how does digitization play a role, right? And then service industry, right? Online delivery, shared economy, capacity reorganization because of the virtual workforce. Many of the workforce has gone into a virtual mode, at least a hybrid of a virtual and a in-person mode. How do you manage virtual workforce, right? Service level expectations and technology driven services. What will be the new technology? So these are the broad domains in which we can categorize the work that is going on in the field, in many different fields, and that will be focused towards, right? So this gives you an overview of this thing. To give you a more detailed introduction to primary challenges of COVID-19 prediction. So I talked about the sparse signal of diffusion pathways during the start of the pandemic, sudden emergence of hotspots that surprised policymakers. So we'll look into that. Latent factors driving the disease diffusion, example, asymptomatic spread through mobility, right? Latent transmission and curse of dimensionality in network models due to global connectivity, right? So it's not easy to model and easy to estimate the diffusion pathways, right? So there's kind of a curse of dimensionality that works there, right? Lack of behavioral considerations, we talked about that, and this is one area where a lot of the work is being focused at this moment, right? Effect of super spreader events were hard to predict due to shocks on the underlying disease dynamics, right? So how do you preempt super spreader events and take preventative measures? I'm not saying you need to prevent the event, but you need to take preventative measures to prevent the super spreader impact from such events, right? Okay, so those are things. So we looked at predictions. That one of the things that CDC did was provide a weekly and a monthly prediction of COVID, right? 1 week look ahead and a 4 week look ahead prediction, right? So what CDC did was they aggregated, they created an ensemble of different predictions, around 20 to 40 different models from different universities and other agencies, and they created an ensemble prediction, and that is what they used to publish as their prediction model. So we looked into that. We looked into that and we saw the error rates. So this is from October 2020 to October 2021, so 1 year period actually, right? So if you look at the errors are pretty high, right? Which is not surprising. There's nothing, it doesn't say that the models are wrong or anything, right? But it's just that the errors are inherently unpredictable, right? Similarly, if you look at the 4 week cases, the errors were even higher, right? So if you look at the top 4 models, so we looked at the top models, right? The Columbia University model and the John Hopkins model, MIT model, and the USC model, right? So these were the top models. These were the best performing models. Even in the best performing models, there's been significant error. If you look at the percentage error, the errors were significant in some cases. In the 1 week prediction, the errors were lower, but in the 4 week predictions, obviously the errors were higher, right? It's not surprising. I mean, these models were pretty good models. These are very robust models, but yet there was a lot of error, right? So what were some of the potential remedies? We looked at machine learning based models. Can you create a machine learning based model which are more sensitive to the temporal changes and the spatiotemporal changes in the time series, right? Bayesian models. So our initial model was a Bayesian model, right? So which can take into account some of the latent factors. So models that consider behavior of individuals and groups, transfer learning from past similar diseases to augment signal. So we talked about sparsity of signal, and can transfer learning help, right? Can transferring of knowledge and information from past infections help? Because if that can help, then the information that we have today from COVID can help in any future infection if there was one, right? So that is something that we looked into, and we will show you some models for estimation of effects of super spreader events on disease spreads, right? So that's another model, right? So these are the examples that I will walk through. I will walk through briefly. So obviously there are papers, and I have provided the links to these papers. You can go in, you can, if you want, you can download those papers and you can go into the proofs and the details of the models, but I will briefly walk through some of these models. The first one that I will walk through is optimal testing and lockdown policies. The second one is policies for school reopening, hotspot prediction using machine learning, modeling the effect of super spreader shocks, and behavioral issues, opt-in versus opt-out policies for K-12. So optimal testing and lockdown policies, right. So to motivate that, we looked at tested positive. You look at these two curves, right. So this is the tested positive. So the people who were tested positive were quarantined, and they did not contribute much to the spread of the disease. What contributed much to the spread of the disease was this black line, right. This is the difference, the untested carriers, right, the asymptomatic carriers, and this is what led to the. So if you can somehow change the curve, if you can somehow change the curve to this way, then obviously you can reduce the infection burden for the future, right. So how do you change this curve? There are two ways to change this curve. One is asymptomatic testing, random asymptomatic testing, mass scale random asymptomatic testing. In our university, in a small organization, it's probably easier to implement. In many universities, not just our university, many educational institutions, K-12, that test to stay program, K-12 schools, we did that, right? We did that. In our university, we developed this saliva-based test, the SHIELD test, and we did mass scale testing. For 1.5 years, everybody was required to test at least once a week, and many at least twice a week, depending on the contact rates, right. So that's asymptomatic testing. That can reduce infection. That's one way we could reopen our classes actually in the fall of 2021, right. So we had full in-person classes in starting from fall of 2021. The other way to bend this curve is lockdowns. That is what was done initially, and there is a trade-off between lockdowns and mass testing, right. So we will look into that. We will look into that. So this model actually looks into that. Okay. So this is nothing different than what you know as the compartmental models. So this was a theoretical work to start with. So we built a compartmental model. The only thing that we created differently was create this untested infection. So we partitioned the susceptible group. Again, I'm not going into the meaning of this, right. The susceptible group into susceptible not symptomatic, susceptible symptomatic. This group is symptomatic from other diseases, maybe flu, maybe common cold, right, but the symptoms are the same, right. Then these are the infected group, right, infected untested, right. These are the symptomatic population. This is the asymptomatic population, right. So this is the infected untested. When you test a part of this compartment, they move into the positive, tested positive compartment, and then you have recovery and death from these compartments, right. So this model falls largely under the compartmental model, where we track the size of the different population segments. So these are mean field models, right. These are mean fields of the individual stochastic models. So we created the mean field dynamics of the individual stochastic models, right. The other way, now this works very well when you are talking of large populations. Mean field convergence is better when you talk of large populations, right. It doesn't work that well when you talk of smaller populations like the university. If you take the university population, 15,000-20,000 people, right, it doesn't work that way, that well, right. And not just 15,000-20,000 people, there were like classrooms with 40 people, and they were interacting with each other, right. The classrooms with 60 people, they were interacting with each other. So there were smaller compartments within this bigger population which had differential risks, right. So these models do not work there. So the other way to do is create agent-based model, where you track the infection dynamics, simulate the infection dynamics of individual agents, and create the uncertainty sets from those individual agent models, right. So that's agent-based model. So, we started with the compartmental models, but we moved to agent based models and we did both, and we have so this particular paper focuses on the compartmental model, right. So, what are the interventions? The interventions are symptomatic testing. So, X denotes the symptomatic testing capacity, right, symptomatic testing capacity. Contact tracing, Y denotes contact tracing, right. So, when you test somebody and that individual tests positive, you track the contacts in the past 4, 5, 6 days for that individual. Now, that is not perfect, that is not perfect, there are uncertainties there. However, you test the contacts and you test those contacts, contact list and test those contacts, right. We will talk a bit more about this when we come to the small population models, right. Random asymptomatic individuals, this is random testing. Now, random testing gives you two things. First of all, it gives you an estimate of the asymptomatic infection burden, right. That is one of the things that the random testing provides. The other thing it gives you is to dampen the asymptomatic infection dynamics, right. If you can do it on a mass scale, right. So, random testing capacity, obviously there are capacity constraints, right. We did not have enough testing capacity, at least to start with, right. Now, we do not have that issue, right. Then the other intervention is mobility, right. FT is the number of people on an average each individual meets, right. So, obviously we scaled it between 0 and 1, right. So, what do we mean by 0 and 1, right. So, 1 means no mobility control and 0 means perfect mobility control, 100% mobility control. Obviously, that is impossible, right. No mobility control is possible, but that was not desirable at that point of time, right. And beta is the infectivity parameters, right. So, we build the infection dynamics. So, this gives you the infection dynamics, these are the testing dynamics, right. So, phi x is the population that tests positive or the fraction of population that tests positive from symptomatic testing. Phi y is the fraction of population that is positive from contact tracing based testing, and phi z is the population dynamics from asymptomatic testing, right. So, we look at what does these different testing regimes do and combine that with mobility control, right. Okay. So, first we try to look at, so given this infection dynamics, right, it's complex, it looks complex, and it is a bit complex, algebraically complex. It's not easy to solve any control models from here in a closed form solution, right. But we looked at, could the COVID infection die out without any testing by itself? Could the COVID infection die out by itself? We know that it could not, but this is just a verification of that, right. So, this is the condition for the infection dynamics to die out, right. So, in our model, this 1 plus beta naught f divided by this or multiplied by this gamma prime, this parameter, right, is kind of the R naught parameter, the basic reproduction number parameter, right. So, that has to be less than 1. So, we took these values from published papers. So, we looked at different published papers from different science journals and took an average value, the range values, and we saw that under no condition, without testing, without lockdown, without any mitigative action, COVID could not have died out. It hasn't died out. It hasn't died out, right. But still, that is the verification. Could COVID die out under perfect symptomatic testing only, no contact tracing, just symptomatic testing? Could COVID die out? So, it could die out in our model, at least theoretically. Again, it could die out in again there are conditions that has to be met, closed population, no external influence. So, those are theoretical conditions and assumptions that we made, right. Again, not always practical, but it gives a directional sense of what could happen, right. So, it could die out if mobility control were less than 60%. So, in a sense, if 1 denotes full mobility, we had to at least control 40% of that mobility. 40% is a huge control, that has a huge impact, right. So, with perfect symptomatic testing, first of all, testing symptomatic testing was not perfect. Secondly, controlling 40% of mobility was not that simple, cost wise not that simple, right. So, it could not have died out really just by symptomatic testing. Could it die out by incorporating contact tracing, right? Could it die out by contact tracing? It could if contact tracing efficiency was very high, and that too in the initial phases of the disease. So, the way contact tracing works is it tracks the chain of infections, right. It tracks the chain of infections. Now, because of the inefficiencies in contact tracing, at some point you will lose the chain, you will just, the chain will break. You can't track the full chain, right, of infections because of inefficiencies. But if you consider theoretically at least that if contact tracing could have been absolutely perfect, right, then it could have died out with contact tracing as symptomatic testing. But from our own experience and from different other experiences, contact tracing cannot be perfect, right. Could it die out by random asymptomatic testing, right. So, this gives the condition for random asymptomatic testing, right, which is Z, the Z parameter. The Z parameter has to be really high for it to die out without any mobility control. So, this shows that mobility control was required to start with for the infection to dampen at least, right. Okay. So, then we looked at, okay, then if mobility control is required, so what is the optimal level of mobility control? Because once you start controlling mobility, you are incurring two different types of costs, and these two costs have trade-offs with each other, right. If one cost decreases, the other cost increases. If you try to decrease the infection cost, the health cost by higher mobility control, the economic and the social cost increases. If you try to reduce the economic cost, then obviously the health cost increases. So, this gives you the total cost, right. This gives you the cost function, right. So, the idea is to what kind of mobility control given different types of testing, right, can dampen the disease, right, can dampen, what is optimal, right. Again, we do not really come up with optimal policies, it's not so easy, but we come up with near optimal policies, right, and we demonstrate near optimal policies, right. So, the first lemma from the paper, I mean, I do not really want to go into the details of the maths at this moment, right. So, what we saw is that that with perfect symptomatic testing and fixed asymptomatic testing and no contact tracing, without any contact tracing, the optimal policy is extremal type, right. So, optimal policy is extremal type. That means what? That it is optimal to either lock down minimally or lock down maximally, right. So, Ft equals to 1 means minimal lockdown, right, and Ft mean is the maximal lockdown. The nomenclature is a bit confusing, I understand that, right. So, this means that this is the maximum control, this is the minimum mobility that you need to have, which means the maximum control 1 minus f is the maximum control that you can have. That is why it says minimal control, right. So, this is a parameter in our model. We do not know what that minimum level is, but there is a practical feasible minimum level. If you convert that to 0, that actually creates a problem with the model first of all, but more than the model, that is just impractical, right. You need to have some amount of mobility, right. So, that is the minimal level of mobility and that is the maximal level of mobility. So, we show that it is a single threshold type model, single threshold type optimal control policy, right. And the threshold is given by this function. Again, I will not go into the details of this. So, the practical significance is that it is optimal to lock down earlier than later. It is optimal to lock down earlier than later. So, many different countries, many different policymakers, many different nations and regions locked down earlier than others. So, that early lockdown was not a bad idea. So, this shows theoretically at least early lockdown was not a bad idea. So, the idea is at the onset, when you see that the infection diffusion has started, at the very onset, if you can lock down, dampen the disease, and obviously this considers a enclosed population, right, then the cost, overall cost is minimal, because we are looking at the lifetime cost of this infection. Then we look at what with contact tracing, right? What happens with contact tracing? Again, we see that the policy is optimal, but it's a sequence of optimal controls, right? So while again we do not really characterize it fully, but this is the nature of the control, that for some time you control mobility to the maximum possible level, for some time you relax it to the maximum possible level. This sounds a bit counterintuitive, obviously, right? This sounds a bit counterintuitive. It seems like there should be a middle path where you lock down for a long time, it should work better. But the way the infection diffuses, the way the infection moves, that's not what is optimal cost wise, right? You are incurring cost by not locking down fully when you need to lock down. So beyond the threshold level of infectivity or the future risk, you need to lock down fully, and then once you reduce it, so there's a upper threshold and a lower threshold. So once you reach the lower threshold, you open it up. So that's the cost. So we did some simulation. We did some simulation with contact tracing and without contact tracing. Again, these are simulated numbers, so these are not real numbers, right? We will come to real implementation, or not of this model, but a similar model, right? Again, we look at different policies: static policy, receding horizon control policy, and switching type policy, that you switch from the lockdown to no lockdown, right? Switching type policy. So we show that at different levels of infectivity, different policies actually work better. The static policy is okay when infectivity is low, but it is really not that okay when infectivity is high, right? So the switching policy is probably better in that case, right? Receding horizon control is not good in any case, right? So receding horizon control is a myopic policy. So you show that the myopic policy doesn't work. If you are undertaking a myopic policy, that doesn't work, right? So again, you can download the simulation. We have made all the data and all the simulation and the codes available on GitHub. We have a GitHub page. You can go and download. All the data that here is available, so you can download all the data, right? School reopening policies, again, we have shared all the data for this. So this is a data-driven approach, right? So what we do here is, and this is the work that we started with, right? How am I doing it time? 8:50. So we have time. Yeah. So this is the work we started with, right? So the objective was to minimize the infection in institutions in our university. How do you minimize the infection in institutions? With testing, and the decision is testing frequency and how much of contact tracing, right? Testing frequency and contact tracing. So inputs are infectivity estimates from data, contact rate, and this, right? So again, we built a model, right? So this is the sequence of actions. You create a contact pool, contact trace. So the first thing you do on a particular day is test these contacts from the previous day, contact list, right? Then there is external infectivity, internal infectivity. There is an untested population, then tested population, there is a recovered population, and again you create contact tracing, and this goes on like this, right? So this is the model. We simulate this. So we first theoretically characterize this model, right? So we take into account internal infections, external infections, bulk random testing, contact tracing, and recovery, right? Again, this is a small sample model. So these equations are derived with small sample assumptions. So it's not a standard compartmental model, right? So we used actual data from our university and several other universities to estimate this. Using this model, we estimated these parameters. These are the parameters we estimated: the base infectivity rate, right? The base transmission rate, the internal contact rate, the external contact rate, the external infectivity, and testing rate. These are given, right? So these are the three things that we estimated. So these are estimated from this model and using real data. Again, the data is available to you if you want to download from the GitHub page, right? So this is what we see. This is for UIUC, and this is for Illinois State, right? So yeah, so we did it for many different universities. So UIUC was a primary focus, right? So using this, so another thing that we show is that external positivity, the community positivity matters. So, there is a dependence between community positivity and the university positivity. When the universities opened up in the fall of 2021, it provided a shock to the community positivity. However, community positivity in turn, so it is a dynamical process, in turn influences the internal positivity, because no university is a closed system, it is an open system, right. So, we show that there is a obviously there is a lot of noise here, right. So, these are like 75 of different universities, right. We show the distributions, right. So, this is the surge around October, November. This was the election time and all the social disturbances that were going on at that time. So, that created a surge, and the universities also had a surge, right. So, this is the distribution from 75 or 110 different universities, right. Okay. So, then we created an agent based simulation, right. So, we created a naive agent based simulation and an agent who is optimizing its action, optimizing the contact rate, right, optimizing how much that agent wants to expose himself or herself to infection contacts, right. So, we created the both the models, and we kind of simulated that. For a small population, the we do not have an estimate of the uncertainties if we use the mean field dynamics only, right. So, the simulation, agent based simulation, gives us a way to estimate the uncertainties, right. So, you can create robust policies, right. So, we looked at robust policies that can, so we show that this testing to the population rate, that what fraction of the population you test every week or every day or every time period, in that sense, it is a time period in the simulation model matters, right. So, we show that around 20%, 20% is kind of optimal, right. If you test 20% of the population every time period, every week for our university, then that is kind of optimal, right. Then you do not waste tests, at the same time you dampen the infection rates, and it did happen that way, right. So, we did test every individual once a week, that is 20% testing per day, right. We also showed some other things, like the rapidity of the test results is more important than the test sensitivity. For the SHIELD program, UIUC SHIELD program, the test sensitivity was around 92-93%, right. It is not a bad sensitivity. Most commercially available tests have that kind of a sensitivity, right. The specificity was higher. So, the false positive rate was lower, right. The false negative rate would be high, but false positive rate was lower. So, the specificity was around 97%, right. So, we showed that it does not matter, even if you can have a test with slightly lower, obviously there are reasonable bounds, slightly lower test sensitivity, but if you can get the test done fast, that is more important. If you wait for the results to come like 1 day, 2 day, beyond 2 days, the effect of testing goes away, right. So, that is what we showed, and that is what, right. Okay. Machine learning based approach. So, that is another approach that is commonly used, and in literature you will see a lot of the machine learning based approach, right. So, we created a machine learning based approach, and this is not for any practical significance or practical implementation purpose, but we first created to understand hotspots. So, the reason why we created this was we were talking to the local authorities, right, and they said that the problem is that we do not know when the infection is going to surge and where it is going to surge, right. So, we said, okay, those are the hotspots, right. In colloquial terms, we call those hotspots, right, hotspots of infection. This shows a demonstration, like this is July 1st, 2020, September 9, 2020. You look at the ICU demand across the United States, right, the hospitalization across the United States. So, this is from New York Times, right. Okay. And this was devastating. We know that this was devastating, right. So, if we could have predicted in some way the emergence of hotspot, and many of these are rural counties, right. Not all is concentrated around Cook County or New York City. Many of these are rural counties, right. So, if we could have predicted the hotspots, especially in rural counties and remote counties where healthcare capacity is normally low, then we could have. The reason it is not easy to predict is because there are not many models which take into account the complex spatiotemporal dynamics, right. So, we try to do that. I do not know, I won't claim that we are very successful or it was better than any other model or anything. The reason I am showing this is because we did it and we compared it with other models. We show that it has reasonable performance. We do not claim that it has the best performance. So, we provide a methodological framework for demand estimation, right. We consider nonlinear dynamical process of disease diffusion, complex spatial and temporal dependencies, and sparsity of data during initial stages of the disease. So, we combined a few different standard approaches to create this model. So, the primary model is a multitask LSTM model, a multitask multi-location LSTM model. So, multitask means we are simultaneously estimating the infection dynamics at different locations. So, the loss function that we use combines the losses of prediction from all the different locations. So, think about all the counties of Illinois, or all the counties of New York City, or New York State, right? New York State or California State or any other state, Texas, for example, right? So, if you this example is from Illinois, right? So, if you look at all the counties of Illinois, the infection dynamics is dependent on each other, right? There's the information that can be transferred by looking at the infection dynamics in one county, Cook County, and DeKalb County, which is just next to that, right? Or Champaign County, or I don't recall the names of all the counties, but there are nearby counties, right? So, multitask means that we combine the loss function incorporates the losses from all these different locations, and it's a multi-location model. Multi-location means that we use the feature vectors for each location to predict the infection for other locations, right? And then we combine that with transfer learning. We look at flu data. We have past 10 years of flu data. Flu data is well tracked. The number of flu cases is well tracked. We have robust data on that, right? Flu transmission scientifically happens more or less, the dynamics of flu transmission is more or less the same as COVID. It transmits through droplets, it transmits through close contact, it transmits through, it's a viral transmission. So, there's enough similarity between flu transmission and COVID transmission. It transmits through mobility, right? So, if it transmits through mobility, the transmission data, if we can leverage the transmission data from past years, there's no reason why the path of diffusion of COVID should be very different from that. It can be somewhat different, but it cannot be very different from that. So, we use the flu model. So, we first use the flu data to create flu model, the same model, and we use those parameters to regularize our COVID model. That helps us address sparsity. So, that helps us address the issue that maybe some county in Illinois, Effingham County, at any time period hasn't seen any COVID cases. So, we have no signal in that county, but flu data can give us some estimation about what can happen in the future if the nearby counties have seen COVID, and how that can transmit to the Effingham County, for example, right. That's what the idea is, right. So, we again these are technicalities, right. Attention mechanism. So, this is basically to take care of the cards of dimensionality. We have too many parameters. If we independently estimate all those parameters, then it's not possible. We will get unstable estimates. So, we create an attention mechanism to share the information across parameters. So, those are technicalities, right. So, transfer learning. So, we show that transfer learning actually improves prediction accuracy in our models when we incorporate transfer learning significantly, very, very significantly, and that is the contribution here, right. So, we use public data. We use data from we source some data from the local health department, right. So, we kind of so I don't show the full results here, right. We have like very detailed results and comparisons, but this is just to give you an idea of how we can use machine learning, which can incorporate complex spatiotemporal dynamics. So, LSTM by itself incorporates long-term memory. So, therefore, it can incorporate long-term temporal dynamics. The multitask feature can incorporate spatial dynamics, the multitask multi-location feature, and transfer learning can address sparsity of data, right. So, these are the three primary challenges, and this is how we looked at, right. Some observations. There's no model that can predict equally better in all contexts. In our case also, you see that multitasking is important in some cases, multitasking is not so important in other cases, right. So, there's you can't have one model that fits everything. So that's one thing that we show here. Transfer learning significantly improves, right? Okay. So again, modeling the effect of super spreader. So this is another stream of models that are used in epidemic modeling. How do you model super spreader shocks? Super spreader shocks had been a big issue in the whole COVID dynamics, right? So there were many examples there. So we look at a few. We look at examples from India and examples from US, right? So you look at the second COVID wave driven by the Delta variant, right? The Delta variant emerged in Maharashtra in India, and then it quickly spread across India, and it coincided with a big event in India, big religious gathering in India, the Kumbh Mela, where more than 40 million people gathered in one location, and then they spread across India. So this provides, within a very short period of time, within a week's time, right? 40 million people coming to one location and spreading, all of them spreading to their location. So then normal diffusion dynamics from the bigger cities, bigger population centers to the intermediate, to the next, that breaks down. There's a shock on that diffusion dynamics, and how do you model that shock, right? That's the thing. So we look at this. So this is the first wave. This red line is the first wave. You see the days since start of first wave and the number of districts over which the COVID cases emerged. It was much more gradual, whereas for the second wave, it was much sharper, right? So this indicates a shock. We create some models. I'm not going into the details of the models. So these are the outcomes. So what we say is that the lack of fit or the change point on the errors of the model. So we do a change point detection, simultaneous change point detection on the errors of the model, the normal diffusion model, and that indicates the presence of a super spreader shock, right? So we did some data-driven work here, right? We look at how does travel impact this diffusion, right? So globally, how did the Delta variant spread, right? So we looked at the Delta variant. So the blue line is, so we looked at this is when the second wave peaked in India, and we look at the travel history between India and other nations, and we see that does this provide any information, right? Because it emerged in India, it spread from there. So we look at that, right? We could have done that for other waves also, right? So we show that, yeah, there is a conformance. Again, it's noisy, but there is a conformance. So these are countries with high diaspora, so high number of travels. These are countries with lower number of travels, right? Then finally, behavioral issues. We talked about behavioral issues, right? And the final piece of work, and this is a very interesting thing that we did, and we like this work. So test to stay program. So the SHIELD program that was developed in UIUC, the state of Illinois adopted that to keep the schools open. So the state of Illinois said, and the test to stay program is from the CDC really, right? That how does it work? In a class, if one student tests positive, the contacts of that student normally are required to be at home for 2 weeks. That was the initial strategy, policy, right? So in the test to stay program, if a student is enrolled in the test to stay program, then the student need not have to, even if the student is in contact, need not have to stay at home, but can attend class provided the student is negative, right? That's all about it. It's a very simple policy, right? So the state of Illinois adopted this. They ran it for a year. We have data on each student, each test they did. So there are around 5 million test results that we have, right, from 1900 different schools. In this paper, we didn't use the entire data. We are using it for different model. We are trying to build a behavioral model which incorporates status quo bias and herding effect of individuals, and try to estimate parameters from there and the distribution of the parameters from there, right? So, but we used a significant chunk of this of the data. We used data from around 600 different schools, right? So there were two policies based on which this test to stay program was implemented in Illinois. One was opt-in, another was opt-out. So opt-in means by default no student will be tested unless the student explicitly opts in into the program. Opt out means by default every student will be tested unless a specific student or the student's parents decide to opt out of the program, right. Obviously, in both the cases the option of not testing or testing was there, right, was equally there. Opting in does not take a whole lot of cost, it is a very simple small form. Opting out also does not take a lot of cost, right. But are there differences across these two policies? As you can see here, the Chicago Public School rejects opt-out testing solution. The teachers wanted to have opt-out policy, where the parents and the guardians wanted to have opt-in policy, and there was a big debate locally as well as at a national level that what policy should you use, opt-in versus opt-out, right. And this debate actually is something that, so the SHIELD program director Ron Watkins, who is actually running the SHIELD program in the 1900 schools, and he is the director of that. So, he is a part of the team, and he said, let us just test out with data. Does it make a difference really? Can we contribute to this debate, right? If it makes a difference, then we can have an objective data driven information that can help policymakers decide, right. So, he looked at the data, opt-in versus opt-out. So, different weeks starting from first week of September till end of November or middle of December, I guess, right. So, this is opt-in, the red is opt-in, the green is opt-out. If you look at the number of students tested, the fraction of students tested, right, it is significantly lower for opt-in and significantly higher for opt-out. There is a statistically significant difference in opt-in versus opt-out in terms of number of tests. In terms of the test positivity across these schools, there is a significant difference, right. Now, one can say that okay, this is endogeneity, right, this is endogeneity. Locations where there were less infection, the communities thought that okay, maybe because there is less infection we do not need to be that strict with testing, right. So, what we did was we also looked at metropolitan versus non-metropolitan, and this difference shows up in every case, elementary school, middle school and high school. So, different types of school, and this difference between opt-in and opt-out shows up in every case, right. Elementary schools, right, this is opt-in, this is opt-out, right. The testing rates are significantly higher in opt-out, right, consistently, and for the positivity, the cumulative positivity is significantly higher in opt-in, right, because you are testing less, right. Testing mediates the relationship between positivity and the risk, right. So, you look at a causal analysis, a match sample causal analysis, that can we compare similar schools which are similar in terms of the community positivity, the population density. So, we had like 7 or 8 different risk factors and we matched on those risk factors. We created a match sample and then looked at the testing rate. So, opt-out minus opt-in, this is what we took the difference of the match sample, right. So, the risk factors are now matched, they are the same. So, to some extent we take care of endogeneity, right. There are debates, does matching resolve all the endogeneity issues? It is probably not, I believe probably not, right, but it still gives you some causal direction, right. So, yeah, this is the last slide. So, we see that the difference is significantly higher. So, that means opt-out schools test more, it's opt-out minus opt-in, opt-out school tests significantly more, and the same shows up for positivity rate. Now, in these two graphs, we did not use the past positivity, the testing rate, we did not use the testing rate as one of the matching sample. We matched on every other risk factor, but not on testing rate, right. Now, we include testing rate and we show that the differences vanish, the differences vanish. That means the positivity, the effect on positivity is entirely mediated through the testing rate. If you could test more, you could reduce the risk of infection in schools, and therefore, the policy matters, right. The policy matters, the opt-in versus opt-out matters, right. So, this is what we show. So, what are the conclusions? What are the lessons learned from this exercise, right? Obviously, again, I haven't been able to cover the entire range of models that are there in epidemic. It's a huge topic in itself. It's a huge subject in itself, right? So, that's impossible, but I have been able to cover a few different models that we worked on. So, what are the lessons learned? First of all, unavailability of the right covariates. Data and unavailability is a big issue that prevents the prediction and preventative measures, right. So, if we can make those covariates, identify those right covariates and make the data available at the policy level, at the national level. So, NIH has done that. NIH has a NC3 cohort initiative. I am a part of that initiative. We have so, as I mentioned, I do a lot of the clinical work. So, we have worked on a paper looking at cancer and the risk of COVID mortality, and we find quite a bit of nuanced relationships there, blood cancer particularly, right. So, if different types of treatments that patients undergo and the risk of COVID mortality, right. So, if we can make those data available and publicly available and usable, that will help future pandemics, right. Global collaboration on learning disease specific characteristics for genomic testing, right. So, when these different variants emerge in different locations, maybe that location, that country does not have enough genomic testing. I think we believe and COVID has shown us that it is the responsibility of the global community to collaborate on that, to identify the emergence of different variants as fast as possible, because it is a global risk. It is not just a risk for that location. For example, Delta variant emerged in India. India has genomic testing obviously, but not enough maybe, right. Could the global community help in understanding the emergence of these different, there is a collaboration that is going on, but I think that can be increased. Reactive policies are suboptimal. Reactive and myopic policies are suboptimal. Behavioral considerations are superbly important. That is something that COVID has taught all of us, right. And finally, resilient supply chains are important, right. And finally, I would like to say that we are now working on a book, actually, me and Sridhar, and we are actually working on a book, and there is a publisher, right. I cannot say the name of the publisher at this moment, but there is a publisher, big publisher, on supply chain impact of COVID-19. First we thought of writing papers, and we started writing papers, but then this book thing came on, and again, so we said, okay, let us write this book, right. So, we are working on that book. We have written a few chapters, right. So, the book is still at an initial stage. So, we would like to invite chapter proposals. So, again, it is subject to approval, right, by the publisher and by the editors, but we would like to invite chapter proposals for this book, right. And that is all I had today. Yeah.
You said you had mandatory testing at your university.
Yeah. Yeah. Yeah.
You found optimal 20%. Did your university do more than that?
So, in some cases slightly more than that. So, for the undergrad students, for a very short period of time, they mandated twice a weekly. Every undergrad student. The reason they mandated twice weekly was that there was this homecoming, and there was a big homecoming gathering. Although the university specifically, there was no homecoming that year, but there was some gathering, right. The university specifically said that there is no gathering allowed in university premises, right, but you can't prevent gathering outside, right. So, there was a time period in September of 2021 when the infection rates surged significantly. So, that is the time when they moved to twice weekly, but for the faculty members and the staff, it was once weekly, but for the large part of the COVID, it was once weekly. No opting out. No opting out. There is, yeah, yeah, no opting out. So, there was no opting out. In fact, students were put under probation for not actually testing, and I must say that I was on the verge of getting a, I do not know if faculty members can get probation, but I got warning letters saying that you are not testing. So, I said I am not coming to office. They said does not matter, you are in town, you have to test. So, then I started testing, right. So, yeah, it was mandated, it was very strictly enforced. If you are in town, you have to test. There is no opting out. There was no opting out for the university. But that cannot happen for the schools. The schools have an opt-in, opt-out, and it's a much larger endeavor, right? 1900 different schools, right? There were 650,000 students. So you are covering 650,000 students, 1900 schools, 5 million tests done so far in a year, right? So that's a big endeavor, right? The testing rate in different schools were slightly different. It was never once a week. It was like once in every 2 weeks is the one that they followed. Yeah.
First of all, it was very interesting and very insightful presentation.
Thank you.
I have two questions actually. My first question is, I believe you mentioned that random asymptomatic testing is a very important aspect of reducing diffusion, right?
Yeah.
So when you're doing in your model, when you're proposing that, do you consider any sort of risk heterogeneity in the population?
Yeah. Actually, for the small population in the in the university, risk-driven random testing is actually the right way to do, because it cannot be entirely random. So it has to be stratified based on the risk, right? Once you stratify it, then it is random, right? In the university also is the same. Like they mandated for a short period of time, at least a few weeks, the undergrad students, only the undergrad students, to test twice a week, right? The students didn't like it, obviously, but that was a risk stratification. Yeah, it has to be risk stratified, obviously, right? Otherwise, you are wasting a lot of the resources, right?
Another question on the same grounds. I believe you mentioned that even if the test sensitivity is low, if you expand testing efforts,
Yeah.
that has a bigger impact.
Yeah.
So I was wondering, have you considered group testing for this?
Yeah, group testing is something that many countries did actually, and group testing is an effective policy that way, right? So you take the samples of the group and you test, and if you find a positive, then you test the individuals, and that's the policy that can be. We didn't model it explicitly, but that's something that is done, and there are papers on that, and we looked at papers on that, especially in Chile. So one of our team members is Sebastian. He is from Chile, and he did work with the Chilean government for some time during the COVID, and he was in the team in the Chilean government. So they did group testing, and they implemented group testing, especially in some of these government organizations and all, right? And group testing is an effective way to do it. Yeah. It reduces, if you have capacity constraint, it's the best way to do it. Yeah. Okay. Thank you so much. I really appreciate you being here. Thank you.